Welcome, Dr. Steve Abrhamowitz, who is the chair in the Department of Vascular Surgery at MedStar Vascular Surgery Program and also the physician executive director there. He's also an associate professor at Georgetown University School of Medicine and a pioneer in new vascular technologies. He's world known for a lot of the new techniques he's pioneered and developed. And recently we heard some interesting talk that he gave at American Venous Forum in 2026. Can you talk a little bit about what you were looking at and what direction you're heading in?
Absolutely. It's a pleasure to be here, and thank you so much for giving me the opportunity to share with the audience for VLU and talk a little bit about debulking inflow and outflow obstructions. For many of us, post-thrombotic disease remains a significant challenge in terms of a lack of toolkit and a lack of options for treating these patients, particularly when we're dealing with segments that inflow into areas that we may want to stent or treat proximally in the iliofemoral region. The American Venous Forum gave us a wonderful opportunity to talk a little bit about the research that we've done looking at multi-institutional outcomes in using some of the newer debulking technologies, particularly the VenaCore catheter from Stryker. And it gave us an opportunity to put this in context for how we could use this technology and think about its utilization for patients and for future delivery of care. When thinking about inflow, oftentimes, and I apologize for skipping ahead, when we think about inflow, it's critical to chronic venous disease, predominantly because we know venous hypertension and valvular damage are two contributing factors to the progression of chronic venous insufficiency. But different from valvular insufficiency, post-thrombotic disease leads to venous hypertension, and historically, we've had very few options that have shown durable results in maintaining luminal patency. Typically, we've been relegated to balloon venoplasty of the inflow segment alone. But unfortunately, when we think about the nature of the disease, post-thrombotic disease generally tends to fall into two broad categories. We have the type of post-thrombotic scar that pulls in the vein wall, leaving you with a very small lumen. And that can respond positively to balloon venoplasty once those fibers, the collagen fibers, are fractured. But on the other hand, when we have lumen-occupying disease, the material that you look at on transcutaneous duplex, and you can see that there is a vein present, but the lumen is filled with something that's hyperechoic, that looks very chronic in nature. That type of material doesn't respond well to balloon venoplasty because there's nothing to fracture. It just gets simply shifted to the side. And so there have been few options to optimize inflow. And that's really important because a lot of the work that was done in Europe by Human Jalai and his co-investigators, thinking about inflow and how it relates to deep venous stent patency in the iliofemoral segment. And for those patients who have 4A, 4B, or type 5 disease, ultimately, if we're dealing with a scenario where a patient has a venous leg ulcer or worsening C4B disease or recurrent ulceration, and they may be in a C5 state and it's refractory to medical therapy, the ability to address inflow becomes very important. So what we were able to do, looking at our real-world experience using the VenaCore thrombectomy catheter at MedStar, Yale, and Allegheny General, was create a multi-center retrospective analysis looking at those patients who had lumen-occupying post-thrombotic occlusion and how it responded to VenaCore and what that patency was for restoring that segment of flow. And we were focusing both on safety, but primarily feasibility and patency to look at were these patients benefiting and were the results we were seeing durable in nature. So we gathered a series of baseline patient demographics, Volta score, patency data based on duplex. We looked at the interprocedural distribution of disease as well as what was removed, and then followed those patients to assess safety as well as their post-thrombotic syndrome scores and looking at if there are any complications as well. It's a small number as the device is relatively new, and thinking about it for treatment segments is really important in terms of risk stratifying. And I would highlight this because right now the device is predominantly used through a 13 French sheath. And when we think about inflow, historically we've only defined inflow as exactly as Human did, femoral vein or the profunda vein. But it's also important when thinking about utilizing the device to recanalize the femoral vein as to whether or not there's patency of the tibial vessels or the popliteal vein as an inflow segment. So we looked at 25 patients where we were addressing a femoral popliteal post-thrombotic lumen occupying lesion who had inflow into the popliteal vein, who could, again, sustain flow in the recanalized segment. The majority of our patients were male. We treated 29 limbs in these 25 patients, and we thought about this in terms of segments: popliteal vein, femoral vein, common femoral vein. Most of the patients treated were unilateral, so there was only one patient where we did bilateral disease treatment. And then we were able to assess how old this lumen occupying material was by looking at thrombus age from when the original DVT was documented. And so that on average was about 36 months. About 87% of patients had pre-existing stents, and some of those stents had issues as a result of a lack of inflow. And again, the symptoms varied from swelling to C4 or C5 disease. When we look at median thrombus removal, 75% of the material based on venography and Marder scoring was removed in this patient population. We did not see any complications related to access site, pulmonary embolism, and I would note when utilizing the device, we are employing distal embolic protection. We did not see any acute kidney injury, and there was no evidence of extravasation, vessel, or valve damage. I would also highlight, as many of us are aware, post-thrombotic scar significantly damages valves, and for those patients who were being treated, they did not have any functional valves to begin with. And of course, there were no deaths. But the key thing that differentiated this therapeutic delivery from others in the past, being balloon venoplasty, was the idea of restoring flow and retaining that patency. And we were able to assess this both by intravascular ultrasound as well as duplex patency. In looking at the treated segments, predominantly the popliteal vein and the femoral vein, pre-procedure, 16% of these patients had what we would have defined as patency, where we could see forward-moving flow with phasicity through that treatment segment. Post-intervention, 96% of the patients had patency in the treated segment. And more significantly is that we saw sustained luminal gain, meaning that the bulky material that was present not only was removed, but at the same time, that vein that responded to balloon venoplasty at that point in time was able to maintain the gain that had been obtained during the procedure. There was also a significant improvement in our Villalta scores as well. Pre-procedure, the average was 8. Post-procedure, that went down to 4. And again, limitations in that this was not blinded. This was performed by the person who had performed the intervention, and the patients knew they were having the intervention, but still a significant difference between pre- and post-procedure results. So this was the first multi-center feasibility study looking at the VenaCore as a tool. Again, it's a nitinol expandable basket that has teeth on the end that allows you to grab some of that bulky material and extirpate it from within the venous system. And it showed that it can be effective with a favorable safety profile at improving luminal gain in a durable fashion that we studied through the study period, that we saw 90% absolute gain in patency and a significant Villalta score reduction. So where this becomes exciting for me is when we looked at Human's data, that was tied into patency of iliofemoral stents. But there was no data that gave us hope saying if you could restore patency and maybe make somebody from a 4A or 4B down to a 3, could you also shift them in terms of their stenting patency category as well? And I think the VenaCore catheter gives us some hope that there is a role for debulking the post-thrombotic scar. There's a tool that can be effective at doing it. And hopefully we have an opportunity here to improve both patency for patients who are undergoing stenting of the iliofemoral segment, but at the same time also restore some flow and lower the likelihood of patients suffering from chronic venous insufficiency with a result of this debulking device. Thank you.
I want to congratulate you for taking this new device and trying to extend its use to where I think a lot of people who were focused on the iliofemoral segment. Now, if we're talking about the femoral popliteal segment, this may actually be an important tool for some of the most difficult patients that we have to deal with in terms of medical management or interventional management, especially those with post-thrombotic state associated with ulceration. Some of these patients are in our office for month after month, year after year, and we really can't get them to make much progress with the standard techniques. I wanted to ask you a question specifically about using this as a not only an adjunct for the iliofemoral segment, but also for combining it with drug-eluting technology to try to prevent restenosis after the initial debulking of the veins. My concern is that if you damage a vessel, is this going to result in subsequent um, scarring due to an intimal injury response? And could we stop that with paclitaxel or other agents? Could this be used as a combination with in combination with other technologies that are being explored?
Absolutely. I feel like this is opening the door to allow us to have better drug delivery should we find that those drug-coated balloons or drug-eluting technologies will make a difference. For the most part, again, because this is lumen occupying, even if you were to deliver drug to the treatment segment, it would collapse back in. And so you'd still have impairment of flow. This begins to allow us to say, okay, we have some demonstrated efficacy and proof. What else can we do to make that sustained in the future? And, I mentioned one, we have to do a better job at patient selection and classifying inflow disease to the inflow disease, which would be the tibial popliteal confluence, and then subselecting the patients. And then beyond that, we have to think about better ways for treating those patients that have disease and post-thrombotic disease that's been removed, especially in areas where we're not seeing results with stents. And so that may be drug-eluting technologies, it may be bioabsorbable scaffolds. There is a whole world of emerging technologies and tools that are available to us. I think what this does is open the door for us to begin to compare. How does somebody do with plain old balloon angioplasty versus how do they do with a drug-eluting balloon? And I'll put on a prayer hat or make an alter to maybe a flexible bioresorbable scaffold, something to really assist in keeping that vein open long enough that it can restore some of its internal structure and flow.
I want to thank you for taking this technology and taking it by the horns and extending it. This is really exciting new technology. Although the results are somewhat small and somewhat preliminary, I think they're somewhat promising because it really helps um, to extend our therapies to patients that we don't have really good treatments for. So again, thank you for agreeing to do this podcast. We really love hearing about some of your ideas and your clinical experiences, especially since the multi-institutional study. Really looking forward to seeing more of this.
No, thanks for having me, and hopefully we can continue to expand on this data and get people better actionable information for patient selection and patency data that they can convey to the patients when consenting them.